let's give you some reaction now to the briefing that was held a bit earlier on by the Health Department on government's response to the Omicron variant. We have Professor of Epidemiology and Public Health, Refilwe Phaswana-Mafuya, who joins us now for a conversation. Prof, thank you for your time. So we first heard from the President, and now we've heard from the Health Minister and your other colleagues who monitor these situations. Just from your perspective, what is your understanding? What do we know about Omicron at this point, and what do you make of what we know about this variant?
Thank you very much for having me. As we have heard over the weekend from various epidemiologists and public health officials and the President himself and the Department of Health, as we've alluded to, a lot still needs to be learned in as far as Omicron is concerned. We do know, with the limited information that we have heard on the cases that have been admitted, that vaccination will work. We know it has multiple mutations, but we know it's something we will be able to handle with the capacities we have developed, infrastructurally, and the human resource capacities. We know that we can, from the past variants, we can utilize some of the mechanisms we've had in place. I mean, evidence-based interventions like, using masks, social distancing, avoiding overcrowded environments, and so on, will still be as applicable as
All right, Prof, I don't know what's happening with your audio from your side. I'm wondering if you are not muted at this moment. We simply just lost audio to your side. I think we've got you now, and I think we can try and continue with the conversation. Just taking it forward, Prof, the word I've been hearing a lot of in relation to the Omicron variant is transmissibility. It seems the main concern,
yes,
more than other concerns that I've heard, at least in the last few days, is that it may be more transmissible than the other variants we have seen in recent months. What are the implications of that from an epidemiology perspective? For instance, in a province like Gauteng.
Mm-hmm. Thank you very much. Indeed, we've been hearing a lot about that. We don't know the virulence, like in terms of disease severity, but yes, transmissibility has come to the fore, and that would mean that we need to adhere to the evidence-based interventions as we know them, which is that we should social distance, wear our masks, ensure that we avoid public spaces, and over and above that, ensure that we vaccinate as many people as possible, because we do know that vaccination works.
And in terms of, the responses, the President telling us that the measures that we have in terms of the lockdown right now will be reviewed in about a week. From an epidemiology perspective, given that transmissibility is the main factor that we are concerned with, could we see a situation where restrictions become inevitable in a way? Because, you've got to break the cycle of the spread. You've got to break the cluster infections, particularly in a period where people are gathering more and more. Or are we past that situation at the moment, in that we should be putting foot to pedal in as far as things such as vaccinations are concerned?
Yeah. Thank you very much. I think we have learned from the past that locking up everything has dire consequences, and that we can encourage more of taking individual responsibility for applying what we know works, being the evidence-based interventions that I've spoken about, using masks and so on. So even if transmissibility is high, of course, there are measures that we will need to strictly adhere to, which in terms of social gatherings, as we know how social events have driven transmissions in the past. So we would need to take individual responsibility to do what we know works. However, my concern is about the living and working conditions of people who cannot adhere to some of the evidence-based interventions as we know them, who are forced, to use public transport, who live in overcrowded spaces, who don't have access, to health care that they should receive, like, with PTSD and stuff like that. That is where my concern lies. However, I don't think we should go back to where we have been. We've seen the damage it has created, and we really want to contain that situation.
Prof, lastly and very briefly, I can't let you go without, asking you to share with us some of your findings. I read somewhere that you've made some, pretty interesting findings in a study that you were conducting around admissions to hospitals. As we start talking about the potential for more and more admissions in the coming weeks, it seems there's a racial dynamic that is at play. How do we understand that? Firstly, just tell our viewers what it is you observed, and how do we explain that?
Well, thank you very much. We looked at the differential impacts of COVID-19 among hospitalized patients in South Africa. We looked at the period between March 2020 and January 2021, and we found that there were differential impacts of COVID-19 by race and gender. And in terms of race, Black Africans were likely to be admitted at a much lower age group than the other racial groups, and they were also likely to die at a younger age than other racial groups. Black African women in particular in the age of 20 to 29 and age category of 30 to 39 had highest hospital admission rates, and we attribute that to their living and working conditions, because we know that as people age, they are more likely, to have more disease severity and hospitalizations and death. But given the fact that Black African women were admitted at a much younger age, it became a source of concern, to say, is it their living conditions, the cultural role they play, the female-headed households where they don't have any choice but to work against all odds.
All right. Hopefully, in the future, we'll have some time to unpack that a little bit more. Professor Refilwe Phaswana-Mafuya, thank you for your time and your insights here on the Midday View